Uh, thank you, Kollam Ophthalmic Association. Edwin, I don't think that much was called for as introduction. Thank you, that is a very flowery one. Overwhelmed by that. Now, this is essentially, unlike most of my talks, it's almost a pure theory talk, and it's about the new evidence that has come in angle closure of late. We all know that primary angle closure is caused by relative pupillary block, and to treat that, we need an iridectomy or an iridotomy. And laser being easier now, we use the laser PI as our first line of defense in closure. But of late, we've been asking questions on that in the newer studies. Do we need it? Does it work? Especially when we have a PACS, primary angle closure suspect, and the PAC, our primary angle closure. That's where we have synechiae and maybe high pressures, but no disc and field changes. The patient actually has no disability. Disc is still normal at these two stages. Do we really need a PI in these stages? What we've known for a long time, we use a very old study now because it's happened in the 90s. I was involved with data collection, though I'm not one of the primary investigators there. 20% of PACS progressed to primary angle closure, PAC, in 5 years, and none had progressed to PACG. And PAC that was detected at the first visit or a first survey, 11% of the patients who already had a PI done at that time progressed to PACG. That is, disc changes occurred in 11% in 5 years' time. A few did not allow us to do a PI. They refused primary intervention, and 36% of those progressed. So we already know that PI doesn't stop everything, but the ones who did not undergo the PI, the overall risk is higher. Chennai glaucoma study again underlined the same. Its incidence of primary angle closure was at disease. This is including all spectrum, PACS onwards, was around 4% in 5 years. That is, those deemed normal at the first investigation. In Chennai glaucoma study, those that were deemed normal changed to PACS or worse in 5 years, and 87% was still only to the level of PACS. So the incidence is low. The incidence of PACG is very low over a period of 5 years, is what these two studies told us, and PI does not protect us all, is what the VS told us already. More recently, to just look at this particular aspect of closure, we have two studies, ZAP and ANALYST. ZAP is Zhongshan Angle Closure Prevention Trial. It's in South China. They screened a large number of patients, 11,000, for eligibility, and found 870 people would fit the bill to be part of the study. PI was done in one eye and the other eye was used as a control, so that the biases were eliminated because it's on the same patient. 6-year follow-up. For diagnosing PACS, they did not use indentation, but they did corneoscopy on all. And 2 quadrants of pigmented trap is not visible, is what they use. And they should not have PAS or disc changes or an IOP over 21. Those who had, they did a prone provocative test on most of them, and those who had IOP rise during that, or anybody anywhere that appeared with 30 mm Hg pressure, was sent out of the study so that it could be managed with a PI in the other eye also. 454 of this 800 odd patients were looked at with OCT also, and they found that 1/4 of them, 26.4%, had residual PACS or the angle did not open up. They also found that a superior PI, a smaller angle opening distance on OCT, that means a narrower angle, a greater iris convexity on OCT, seemed to allow for the PI to open up the angle more. So, in other words, they concluded that superior PI location is better, though they did not tell why the PIs were not all superior or where the PI was put. Is there any particular rationale for that during the study? But I think I also agree with the superior PI as opposed to any other location whenever possible. Some patients you do need to go elsewhere because there are no crypts superiorly. In the ZAP results, 4.19, that's about 4 uh, progressed in 1000 eye years as they reported it, as opposed to 7.97 in the untreated eyes. 4.19 with the PI and 7.97. Again, about half. Primary outcome occurred in 19 in the post-PI and 36 in the untreated eyes in the 72 months follow-up in the 800 odd patients. So when we look at the risk reduction, we find that some people did progress despite the PI. When you compare the two populations or two eyes in this case, two situations, PI gives you a 50% protection. The chance of getting a closure is reduced. But when we take the number needed to treat, you need to treat about 250 of this population, this is all South Chinese, for one person to benefit. So that brings us to the analyst study. Analyst study, some of the investigators are the same. It came back to back after the ZAP was started. So they factored in some of the issues that were there with ZAP. So it's actually a stronger study. Again, they looked at PACS suspects, multicentric in Singapore, 480 individuals who have over 50 years, and two-quadrant apposition. Both eyes were used, and PI was in one eye and the other eye control. Outcome they looked at was synechia or a pressure going above 21 or progressing to a glaucoma per se, that is optic neuropathy, or developing an acute angle closure. They put that at the start of the study as opposed to ZAP. But this is where we have a little problem. Most of the patients are Chinese. 92% was Chinese, and Singapore is a mixed population, so the rest were Malay and Indian. So with the eyes treated over 5 years, 24 reached the endpoint, that is 5% of the population that was studied, as compared to 45, that is 9.4% of the population without the PI. In other words, PACS to PAC was 5% with PI, and without PI 9.4. Again, about half. The hazard ratio for progression without PI versus with PI was again half, 0.55. They also found that the hazard ratio goes up if the patient is older, if the IOP at baseline is more to start with, the hazard ratio goes up, and in other words, an older patient and a higher IOP at presentation is a higher risk, which gets better results with PI as opposed to just watching it. So here the NNT was 1 in 22. The risk without PI is 9.4, that's about 10%. Risk after PI was 4.4, and so the NNT is 100 by 4.4, that's 22.7. 1 in 22 patients who had PI would benefit if you do a PI at the PACS stage. So we know that the risk of progression reduces to half with PI. That has been defined by these two studies. Absolute risk of progression without PI is also not very high. So we are justified in doing a PI in patients, but we are also justified in just watching the patient as the risk is low. But we cannot avoid gonioscopy and IOP follow-up even after PI. That's probably what the take-home message should be. Because we tend to think PI treats it and now the patient is safe. It's not so. Quite a few can go on to develop glaucoma even with a PI. So that brings us to other issues of closure. Lens vault has been looked at as a cause of closure. The first study to come out with OCT coming into the picture was from Singapore. PSC and PACS, that's ones with possibility of closure, had a higher lens vault. And lens vault, by the way, is when you take a line across from the scleral spur to scleral spur, how much of the lens sticks above it. This in microns. So 775 versus 386. The lens vault is higher, is what they found. More in women, and it increases with age. Stuff we knew, but now it's been proven. In Korea, they looked at PSCG, a more advanced disease and a different population, of course, and they found a much bigger difference in lens vault compared to the controls, which are deemed normal. So we have proof now that lens vault is a problem that contributes to shallow AC, which would contribute to glaucoma because of closure, and that brought us to the Eagle study. I have quite a few issues I'll bring into that about the study per se. It was looking at age 50 plus, and it was looking at early lens extraction as treatment for primary angle closure glaucoma. So they looked at newly diagnosed PAC. These are people with synechiae and maybe pressures going up but no disc changes. And PAC with 30 mm Hg or PSCG, that is with pressures of 21 or more with disc and field changes. So they looked at the more severe spectrum than the PACS. And they looked at people with no cataract clinically and no previous history of acute closure. So this is verbatim, but I want you to notice this one statement they have made in the design of the study description. We therefore calculated that the study would have a 90% power at a 5% level of significance to detect a mean difference of 1.75 mm Hg. That would come in when I bring in the results. And another thing that was there in their methodology, which I could not understand what exactly it means, is one of the things they looked at is quality of life with the two interventions, PI versus lens extraction. And to account for missing answers in the questionnaires, we followed the author's recommendations. I don't know how that would become the patient's answer. Anyway, they looked at 800 and something patients, enrolled 419, and randomized it to the two limbs, that is to clear lens extraction versus laser iridotomy. A few people dropped out because data was incomplete, and finally they had 200 odd patients on both limbs, comparable numbers 204 and 205 which were included in the final analysis. There's one with PI, one with clear lens extraction. They reported a higher complication rate in the PI group, which was surprising. So I went into the tables. I'll show you the table. 25 had complications in lens extraction, 50 had in PI group. So you look at the complications that are described. In the PI, there's a huge number who had hyphema, which we very regularly see. 16 of the 50 was hyphema. And then intolerance to medication. Obviously, people who had PI would have medications going on than somebody who had more drastic surgery. So 10 was there. So that's 26 out of the 50 go there. But you look at the severity of the complications that are actually described in the table but not in the text. Your posterior capsular rupture, iris prolapse, vitreous loss, broken haptics. And another surprising thing is there are two patients with malignant glaucoma after PI. That can happen, but this is a very high incidence for laser PI. And one malignant glaucoma, as I said. But in that significant difference between the two complications, I think you should read between the lines and see that the complications can be worse in a surgical intervention than a laser. The IOP, they found a mean difference between the two groups of 1.18, and that was favoring the lens extraction, and this they have reported, and this is touted as the big take home of the study generally, but this is why I brought in. The study was powered to look at a difference of 1.75. They got a lesser difference and they still reported it. And the main thing was they said the quality of life was better in the lens extraction group than the PI group, and that was very significant p-value that was recorded. But mind you, here they have scored 204. The favorable answers in the questionnaires get the number. So from 204, both groups dropped to 176 and 175. There's actually a difference in the mean of only one question. So when you look beyond the statistics, it doesn't look that significant. Also, most of them are hypermetropic, and just removing the hypermetropia and giving him emmetropia with change with the intraocular lens probably will account for that one question. Then the other issue I have with Eagle is in the baseline characteristics. I won't ask you to look at the whole table. Gonioscopy for angle closure, after all, they're looking for angle closure. They have missing data. They've looked at 400 patients. And cynical closure, they have missing data of 247 out of the majority of the patients did not undergo an indentation gonioscopy to look for cynical closure. And they have a significant number, 23, without even a gonioscopy coming into the study. So, from a glaucoma person point of view, this study, though they looked at angle closure, I feel that it was lacking there. The other thing is the demographics of the population of Eagle. And if you look at it, 128 out of 419, I've put it in a rectangle there, were Chinese, and quality of life scores are on the this side is quality of life, and this side is intraocular pressure. And if you look at the, for some reason they put favoring standard care, that's PI in one direction in one side of this table, and favoring clear extraction in the other side. Whatever it is, if you look at it, the only significant bar that they're showing is the Chinese. It favors clear lens extraction on the quality of life as well as the IOP control. If you look at the rest, it is not consistent. It is going this way, that way, and the real results are in Chinese population. So Eagle really cannot be extrapolated to the rest of the ethnic groups. So what do? From PSCS to PSC is a very low incidence. So PI or watch. Once you have a PSC or a PSCG, you have a bigger rationale. You should put in a PI anyway. But PI does not prevent progression in all. So doing a PI does not absolve one of the need to follow up the patient, especially with IOP, disc evaluation, and gonioscopy at least once a year. Clear lens extraction's role is still unclear because we do not have enough proof in all ethnic groups. Lens vault also, though we know it is to blame, the indications to intervene when there is a lens vault is yet to be defined. In general, they say if you've got a lens vault of 1 millimeter or more, you should consider lens extraction as an option also, but there is no hard and fast evidence yet. But definitely, if you have a cataract and some symptom to attribute to the cataract in a patient with closure, PSCS, PSC or PSCG, you would opt for an early cataract surgery. What I'm saying is, if you do a cataract at this level of symptoms in X normal patient, you would do it much earlier in a person at risk of an angle closure. That much we have evidence for. Eagle is supporting it, but Eagle is not strong enough to go for clear lens extraction yet.